Buenos días para todos y todas. Este
Good
evento se
morning, everyone. This event has simultaneous interpretation in Spanish, Portuguese, and English, and you can select your language by clicking on the globe um, at the bottom of your screen. On behalf of Bajo, we would like to welcome you to this webinar, and we are focused on primary health care on opioid overdose. I am here today from Washington, D.C. at the headquarters. I will be coordinating this event today. This event wouldn't be possible without the support of our presenters, and we thank them for their dedication today. And we would like to also thank our colleagues uh, in Washington and those from the country offices and other agencies. And we are going to start, and I will make a brief introduction. By way of introducing this webinar, we're going to present here what the burden of disease caused by opioid use disorders in the region of the Americas. This information has been taken from the study from 2019 by WHO, and we already have information available from 2021, which is being processed for its final publication. We also use the results from the multinational collaborative study by the University of Washington in Seattle called the Global Burden of Disease, Injuries, and Risk Factors, or GBD. In the world, we have 450,000 deaths a year due to opioid use. In this estimate from the year 2019, this is the main mortality problem due to drug consumption. But we need to take into consideration that mortality doesn't provide the whole picture of the burden of disease for individuals and populations. And therefore, the global uh, uh, disease burden uses the dailies, which are disability adjusted life year, a time based measure that combines years of life lost due to premature mortality or YLLs and years of life lost due to time lived in states of less than full health or years of healthy life lost due to disability or YLDs. A daily represents losing 1 year or of full health. The dailies are the sum of years lost due to premature mortality plus the years lived with a disability due to disease or health condition in a given population. Despite not being the most prevalent substance use disorder, opioid use disorders is the largest contributor to dailies. If we evaluate the causes of dailies in the Americas, we see that disturbances due to drug use came from position 45th in 1990 to position 15 in 2021 in our region of the Americas. This represents an increase of 251% in that period. The causes of dailies in the North American countries and drug use disorders then went from position 26 in 1992 being number 3 in the year 2021. This means there was an increase of 380%. If we evaluate a more specific causes in the Americas, level 4 of causality, drug use disorders came from number 67 to 16th position in 2021 from 67th in 1990. And in the countries in North America, opioid use disorders moved up from 31st in 1990 to the third position in 2021, which implies an increase by to 500 an increase of 553%. Here we see the trends in increase in standardized rates per 100,000 inhabitants with respect to uh, opioid use disorder. And definitely the problem is greater in males, and we can see the growing trend in the countries in North America, which makes the global rate for all of the Americas continues to be high and growing. Here we can see a comparison of disability adjusted life years or dailies due to drug use disorders. We see a problematical situation by far in the countries of North America, but there's also an increase in Central American and some Central American countries and in some South American countries. Opioids represent the highest percentage of disability adjusted life years dailies in North America, 83%, and even higher to the global indicator of 75%. But the dailies for North American countries were 1800 years as opposed to 183 years globally. If we compare countries in North America, we see that the opioid problem is lower proportionally than the global situation. However, the dailies, the disability adjusted life years, is closer to 50% in the whole of the subregions in the Americas, followed by disorders due to consumption of cocaine and amphetamines. Age standardized deaths per 100,000 population caused by drug use disorders in the region of the Americas in 2020 shows 78% due to opioid use disorders, very much higher than the global indicator and the indicators for all the other regions in the Americas. Again, if we take a look at this again, excluding the countries of North America, we can see that mortality per 100,000 due to drug use disorders is much higher than at global level, but opioids are very significant in some subregions, and we see that cocaine is still with the one with the highest proportion. To sum up, then, the burden of disease, the disability adjusted life year or dailies are a crucial indicator for prioritizing public health policies because they show the important impact of drug use disorders on population health. Mortality and disease burden caused by opioid use disorders in the Americas is higher than the global average, a situation which is primarily driven by countries in the North American region or subregion. The burden of disease regarding opioid use disorders accounts for about 50% of dailies due to drug use disorders across American subregions in excluding the countries in North America where it is 83%. We must improve access to comprehensive prevention and treatment programs in the region in order to reduce the burden of disease caused by opioid consumption. And very certainly, we will hear more about it when we listen to the presentations of our invited guests. And without further ado, now we will continue with our next presenter, Dr. Silvia Cruz Martin del Campo, who is a biologist from the National University, the Autonomous National University of Mexico. She is a pharmacologist and has a master's and PhD in that discipline. And she has also studied a fellowship in the Virginia Commonwealth University. And Dr. Cruz is a neurobiology researcher in opioids and addictions. And I leave you now with Dr. Silvia Cruz Martin del Campo. Good morning, and thank you very much for the opportunity to be here with you discussing this very important topic. The topic I will be discussing today will be a discussion of general concepts, and I will try to do it as best I can. Above all, I would like to tell you that the word opioid is used in different ways, and I would like to talk about its etymology. It is extracted from opium, which is the milky substance from the poppy pods. When they lose their petals, they have this immature fruit of the poppy. And if you do small slits or incisions on this pod, eh, there is a substance that is leaked and it is milky initially, but then it becomes brown. There are confusions also about the use of the terms. The broadest term is opioids. However, we must understand that it also includes natural peptides that are synthesized by our bodies, the enkephalines and the endorphins, as well as the poppy derivatives, which are called opiates. And I will tell you why. And there are others that don't look at all like the original uh, extracts from the plant. They are structurally very different. However, they have similar effects, and those are called opioids. Fentanyl, therefore, is an opioid. The more encompassing term is opioid. When we talk about opiates, we are calling about morphine or things that are similar to morphine in their in their effects. I will give some examples later. The effects when we talk about opioids are analgesia, euphoria, sedation, meiosis, which is pupillary constriction, cough suppression, and constipation. These effects are desirable. Many times, constipation was treated with this was treated with opioids, even to treat diarrhea. How and people are in pain, they are also given opioids. When you use it repetitively, there is tolerance that increases, and there is dependence, which we will discuss later on. And there are effects that suppress the immune system, and therefore, uh, there is a tendency to have diseases and endocrine problems. We have very interesting compounds which originally were extracted from plants, and we learn about them. They are excellent analgesics to treat intense pain, acute pain, not for all chronic pain, however. And here there is a problem in the Americas, and it is that there are not enough opioids or morphine to treat pain. On the other hand, these substances are dangerous drugs because they can be abused, and abuse has been increasing. On the one hand, we have a lack of opioids to treat pain, and on the other hand, we have abuse substances that are available on the market. And now let me talk about the origin and the basic definitions. What are the opioids that we have? We have natural opioids, which are those taken from the plant in addition to those produced by our bodies. And then we have morphine. Morphine is a 100% natural substance which has a chemical structure in particular, as shown here in the drawing. And we have three characteristic parts: a nucleus of three stable rings, then a green one, and the pink one there, which has one nitrogen. And we know it is essential for the opioids to have their effect to have a heterocyclic ring as the OH here, and the pink one, which has a nitrogen. These are the basic parts that bind the sites in the body. So, from morphine, if you make small changes and you tweak with it, and instead of having OH, we have the acetyl groups, we will then have heroin, which is by acetylmorphin, which is very similar, and it's still considered an opiate because it has a very similar structure to morphine. You need to cultivate a hectare of poppy to obtain 16 to 18 kilograms of opium. And there's plenty of work, labor intensive land being cultivated to have this kind of yield. We have synthetic opioids, which are fully synthetic, like fentanyl. Fentanyl has been known since 1960. It was synthesized by Paul Janssen. We know it's a great analgesic, and it acts very rapidly, and it is used for anesthesia, and it is also used non-medically for euphoric purposes. And our experience with medical fentanyl has been very successful and very, very beneficial to patients. However, when it is used as an abuse drug, it becomes an excellent business. Why? Because it is 50 times more potent than heroin. And we use this tip of the pencil to show the very small amount which can cause death. It is very easy to produce fentanyl. It is very powerful, very potent, and it can be stored in small volumes, and it yields great profit. 1 kilogram of pure fentanyl is so powerful that you can have a half a million of lethal doses, and you can produce it in a few hours in a laboratory. You don't need land to cultivate hectares. What does it mean that fentanyl be 50 times more potent than heroin? Many people think that it is stronger, that it has a stronger effect. But what this means is that you need 50 times less to have the same effect as heroin. So these are two different concepts in pharmacology. If it were morphine, it would be 100 times less. So the amount needed is very small, but the effectiveness is the same. To now refer to other opioids that don't look like morphine in structure, let us give you here an example, fentanyl. When we talk about fentanyl in general, we are talking not only about the substance that we are showing here, but also many analogs. We could talk about fentanyls in plural. So, what is a fentanyl? It is a phenylpiperidine. And let me show you here the heterocyclic ring, which is the phenyl group. And in the red portion, there is the ring with a nitrogen, which is the piperidinic ring. Remember, I had shown it with different colors. They were essentials for opioids to bind with their receptors. They no longer look like the like morphine or heroin, but they have the key elements needed for binding. And then in the lower portion, that's when we have the different analogs of fentanyl. We not only have fentanyls, we also have new psychoactive opioids, which are non fentanylic. there is a trend to synthesize substances that are used with a specific purpose to generate dependency, uh, which is anti pharmacology. Uh, they are used without having done clinical studies, of course, because they wouldn't pass those studies. But knowing that by structure, they can have affinity for the binding sites of opioids and then would have significant effects. For example, brorphine U47700 MT45, which are just codes that are used by pharmaceutical industries, which develop them with legitimate purposes, trying to make them into uh, good substances. But when they found out that they were highly, that they would lead to dependence, they didn't continue to develop them. But others use them for marketing purposes now. And here we mention other substances that are on the market, and we have the metacines, and we're going to talk about what they do and how they have their effect. Out of all the groups, we can have complete agonists of opioids. They have a similar effect to morphine. And we can have partial agonists as well that produce a lower effect than complete agonists. And we also have other agonists which activate one kind of receptor, and on the other hand, they antagonize or block another type of receptors to opioids. And then finally, we have the drugs that only bind the opioid receptor, but they have no effect. All of them are significant. The concept of partial agonist is very specific. My example is that it's like a lazy worker, someone who just there, but they work poorly, but they prevent another good worker to do their work. And this is very important for treating people who have opioid dependencies, because when you give them a partial agonists, the heroin cannot no longer have the original effect. However, they maintain stable and without having withdrawal symptoms. And so all of these agonists have specific uses. We have several examples of clinical use opioids, morphine, heroin in the United Kingdom with the name of diamorphine. In chemically, it's diacetylmorphine. It's a very good um, analgesic used in the hospital. Oxycodone or Oxycontin, as is called in its different release mechanisms, and you have the others. And then at the end, I have a partial uh, agonist and other drugs, which are nalbuphine, naloxone, naltrexone, which block the action of morphine and heroin. Why is it very hard to stop using opioids when people have become dependent? Well, because they liberate brain uh, substances like dopamine. Dopamine is a signal that by evolution we have developed to learn that what we have done is important and then it is worth repeating. And therefore, we repeat the same behavior. And this is something that has a rewards a system, and it gives a false signal that using drugs is important and we must do it. And so opioids act on receptors that are whose agonists, whose natural agonists are our own endogenous opioids, which are released when we have pain and or when we uh, uh, do exercise and we feel pleasure. So they speak a similar language than our bodies, and so they are well received by our bodies, and they bind different receptors, reward receptors, pain resort receptors, in immune system receptors, and they send signals that are very difficult to revert. And Now, talking about withdrawal symptoms, people who consume drugs feel terrible when they stop using drugs because they have all those mechanisms. There's anxiety, muscle pain, as if they had the flu, with joint pain, etc. And things get worse and worse. There's vomiting, diarrhea, and this lasts about a week, and it's a terrible, very uncomfortable situation. We also have adulterants or cutting agents. And we need to talk about xylazine, which is mixed with opioids. It's an anesthetic. It is a veterinary use substance. I cannot talk about its effects, but what I can tell you, or I can tell you more if you're interested, there is a webpage that we have uh, which discusses the effects of these different substances, these cutting agents like xylazine, and uh, and with this QR code, you will be able to access that page. And now I would like to end my presentation, and I am at your disposal for questions after the other speakers have given their presentations. Thank you very much, Dr. Silvia. You have given us a very significant overview of the risks of opioids, their mechanism of action in our bodies. And you have also talked about how easy it is to produce fentanyl and similar drugs. If there's if it's easy to produce, then the business is really good and big for those who are engaged in that. And in addition, the addictive potential is higher, and therefore a higher risk of mortality or lethality. You also have mentioned the risks of mixing fentanyl and opioids with other drugs like the cutting agents, which make treatment harder for those people who may having problem, and it really makes the situation worse. Thank you, Dr. Sylvia, and please stay on for questions in the end if we have time. Thank you. Now I will invite Dr. Ana Maria Cano Renteria, who is a doctor and she's a specialist in psychiatry from the Universidad Rosario in Bogota. She is a scientific coordinator of hospitals specializing in addictions, and she is an active member of the Colombian Association of Psychiatry and specializing in substance abuse. She has been an advisor for the UN Office in of drugs and drug use. Over to you, Dr. Ana Maria. Thank you very much, Dr. Mario. It is a pleasure for me to be here with all of you in this webinar, and I'm going to focus my presentation on early detection and how to manage opioid overdoses, both in primary healthcare as in the community.
The first message is to tell you that at any rate, I apologize, but there's something on the screen says the presenter, but as we heard before, the opioid overdose may be lethal. But in spite of that, there are strategies to avoid those deaths. And we already heard about the dimension of those deaths, but also the scope of the dependency on those substances. We also heard about this a little bit in the previous presentation, but opioids have three important effects on the brain. On the one hand, they convey the feeling of pain, and that's why they are useful in medicine. They also activate the reward center and also give us the idea of pleasure and make people feel that they can get easily addicted. This is what we see in trials, and they can block pleasure, rather the automatic respiratory centers that are in the brainstem. So that activity, and in the medulla, that activity on the brainstem is responsible for the brain, for example, to stop breathing. This is a medicine that that leads to an impairment of the respiratory or the breathing function, and that is the leading cause of death. There are some people that are at higher risk of being vulnerable to overdose, such as people who inject themselves drugs, since the drug goes directly into the bloodstream. The drugs flood the brain within seconds. As Dr. Zapata showed us, this is typical among adults and younger people, and in particular, those that are polyusers. Within this group, they do not know, but these also include alcoholic beverages and barbiturate, fentanyl, benzodiazepine, all of the substances mentioned by Dr. Sylvia that increase the possibility of an overdose. What are the risk factors? We should not forget that everything that is related to our health includes individual factors, environmental factors, and also factors related to substances. So who? Those who have disorders due to the use of drugs and the permanent need to use a little bit more to block the withdrawal syndrome, and for that reason, they use too much, and also the experience of using new drugs or new pathways, in particular those that are living a prolonged withdrawal period, those that are undergoing detoxification, those that are being treated for drug abuse, those that move from one country to the other. And as we have seen in Colombia, simply there is a lack of methadone in the country, and we have nothing to offer them, anything that has the same level of effectiveness for those that are being treated as part of these programs. For those that are using opioids, that are being medicated due to pain, the reason that they have a higher frequency of consumption or use also makes them more vulnerable to overdose. Clearly, all of those that have some other physical problems or mental health problems are also at greater risk of overdose. Out of all of these factors and groups, clearly, the main risk factor, in my opinion, is precisely not having easy and timely access to medicine to reverse the opioid overdose. And here we are going to start to discuss, and this is not the only antagonist, the naloxone. For primary care, the primary care community and people in the various environments, there are three characteristics of this intoxication with opioids. We have a triad. The person starts to feel sleepy, starts having diminished alertness or awareness. The breathing becomes superficial or clearly stops breathing. Finally, if we open up their the eyelids, we are going to see that the pupils are very small, very, very small. They look, they have also nausea, vomiting, and this also makes the situation more complex because the person may also reabsorb their own vomit. So we are going to see the various scenarios where we may have an overdose. Clearly, among opioid users, those for recreational reasons, fentanyl, heroin, etc. And it could also be because of an intentional voluntary overdose in an attempt to commit suicide, or for example, an attempt to commit a homicide. It could be an incidental situation, for example, in a place where there is someone who has prescribed opioids, the grandmother, the son, the mother makes a mistake, and for a brain that has never received opioids, a small dose may be lethal. And clearly in clinical settings. So where should naloxone be available at all times? Among users, their immediate group, wherever they use, for example, they need to have that at hand. And clearly in the households where people have prescribed opioids or opioids for recreational use, and also in the community settings. For example, the same way they go and buy the needle, the one that they like, at least in Colombia, at the very least, the naloxone should also be offered. It is over the counter and with very brief instructions that can be perfectly used. And we are going to see the naloxone. Now, for example, in those addiction centers, this is where it is used, and also independently of the fact that they may have patients with that use opioids, naloxone should be available in first aid kits and also ambulances, hospital services, and also in the medical settings and emergency services. So naloxone is not only for a place or a specific area, it should be more available and at hand for everyone. So how is an opioid overdose treated? How am I going to avoid death in that situation? Well, the two basic first aid rules, and also by the administration of naloxone. It is the only situation in which the whole process of trying to recover the person, and that should be done even before doing any sort of administration of any medicine, should be by administering naloxone. Here, this is a very useful video in a very easy to understand language for the population in general. Naloxone is an antagonist, as the previous doctor mentioned. In Spanish, is an antidote against opioids. And if it is administered timely, we can reverse the effect of the opioids in the medulla, and the person may be able to regain the ability to breathe. We need to understand that the naloxone has a long history of safety. This is not something that was just invented. It has the advantage that it is not only safe, but it is only used for opioid overdose. It does not have an impact on anyone who has not been using opioids. It is not addictive, it does not lead to euphoria, and it may be easily administered by individuals in the community who are briefly informed as to how to use it. As you may see here in this slide, naloxone is is distributed in vials, and when that, now there is a special device, when that device comes in contact with the skin, the substance is released intramuscularly on the arm, the leg, or the buttocks, and it is also in nasal sprays that are even safer, meaning that there is no need to break the skin barrier. The nasal device is introduced and a shot is administered. If the person does not respond in 2 or 3 minutes, or the person responded and it went back to losing consciousness again, there is a need to continue to apply another dose or a vial, an injection every 2 or 3 minutes until the person wakes up. There is also here a link to a handout that is very easy to understand for the community and that can also be used in the various territories. Whenever we are faced with this emergency, we need to call the pre-hospital services and professional help. The person cannot be left alone. We need to wait for someone to arrive for help. And if the person used naloxone, the person wakes up, sits up as if nothing had happened. The person is alert, may respond to our questions. But we need to recall that naloxone, since it is a powerful antagonist, may also lead to withdrawal symptoms within 40 to 50 minutes. What should we do when we have this situation within the community? We believe, and this is something that we saw in the guidelines document for the care of individuals who use substances in Colombia. As in any other drug, there should be an onboarding given at the primary health care centers to the authorities that patrol the areas where the consumer spends most time, services, and also centers where assistance is given. These should be individuals who are onboarded on the use of this medicine, who can identify and use naloxone to save lives. And I leave you here with these questions for discussion later on. This is something for the participants to ponder about. Naloxone is a medicine that is sold over the counter. There are instructions on the box where it is sold, but strikingly, and also in spite of everything that Dr. Mario mentioned, it is very difficult to obtain it in several of our countries, and it is not even available in ambulances in some cases, and the pre-hospital services do not even have it, and it is not even available at the first level emergency services. And this is a paradox because today the WHO PAHO Strategic Fund includes as part of their drug list spray naloxone. That is to say, why is it that we do not have access to this? Why is there such a scarcity when it is needed right now? And I leave you with these questions for the end. As to recommendations, once we have saved that person's life, we need to advise that person to go to a hospital. And if the person doesn't want to go, we need to offer some basic suggestions not to use any substances, in particular anything that may have a depressive effect. There are some long-lasting substances such as methadone that may continue to have an impact and effect on the person 36 hours afterwards. And if this is related to a suicidal attempt, then we need to reach out to the competent authorities to ask the person to go to the emergency room to be assessed in a comprehensive manner. Finally, I would like to address treatment with medicine. We should not only avoid the overdose, but also the individuals that use opioids need to have access to treatment with medicine, not only to protect them from future overdoses, but also help them recover. And it is difficult, sad to see that even though we have great significant evidence with methadone, morphine from earlier years, they are not widely used in the services or treatments. This is not only due to structural barriers, but I think that this is also related to the stigma within the medical community and having colleagues that still say that handling or managing a patient with this type of treatment with methadone is nonsense, and this seems a little bit out of touch with reality. And we know that even if we have fentanyl, if we are faced with fentanyl, we do have evidence about the use of methadone in a positive manner. Why shouldn't we use it? And finally, it is necessary to understand that the substance abuse disorders are not foreign to the mental health of the individuals. So we need to have a wholesome evaluation and treatment of the individual. That is key. And I think that with this, I conclude. Thank you very much. Thank you very much. Your participation leaves us with some clear concepts about the risk of overdose due to opioid use, the message that there is a need to facilitate access for people to the antagonists, to offer proper treatment at the time of overdose and emergency, and to avoid death due to the use of opioids. You also defined incredibly well how to recognize individuals that may have problems with overdose, so that it could be any person in the community, not only medical practitioners, who can identify this intoxication with opioids. And you're also asking for the use of methadone, and clearly WHO PAHO Strategic Fund does offer the medicine, and they can obtain this by means of the representations and the health ministries. They can liaise with our own strategic fund and in a way have availability of the medicine in our countries. So that is very important also, as you mentioned. And Dr. Ana Maria, we thank you for your presentation. It has been a pleasure to be with you. Now we welcome Sarah Weckman. Sarah Weckman is the Senior Medical Director for Substance Use Disorder at Mass General Brigham and Medical Director of the Program of Substance Use and Addiction Services at Massachusetts General Hospital. She is an Associate Professor of Medicine at Harvard Medical School. She is a researcher on addictions, publications, and experts in the treatment of patients with opioid addiction. Welcome, Dr. Sarah.
Wonderful. Can you see that okay? I'll
No,
assume yes. Yep. You can see that all right?
no la vemos todavía.
We cannot see it.
Yes or no?
No,
No.
we cannot see the slide. No,
Can't see the slide?
no, no.
Okay, let's try again. Share.
Okay.
Yes?
Okay.
Okay, thank you. Well, I'm really pleased to be here. Thank you so much to Dr. Zapata and others for inviting me. And I'm going to be talking about addressing opioid use in primary care settings. As you've heard already, the United States leads the globe in overdose deaths. We have the highest rate of drug-related death compared to many other countries across the world, and yet we have one of the lowest rates of treatment for opioid use disorder with life-saving medications like methadone and buprenorphine. Thankfully, we have decades of research showing us what are effective treatments. Methadone treatment and buprenorphine treatment are the two therapies that have been shown to reduce mortality, both all-cause mortality and overdose-specific mortality, where when people are engaged in treatment, the risk of dying from any cause decreases significantly. Methadone and buprenorphine are also the only treatments that are associated with reduced overdose compared to all other types of treatment. This study looked at 5 different treatment pathways compared to no treatment and found that only methadone and buprenorphine treatment were associated with a decreased probability of experiencing a subsequent overdose. In contrast, naltrexone treatment, inpatient detox or residential treatment, or behavioral health treatment alone did not have an impact on the risk of overdose. When we look at clinical trials that compared buprenorphine treatment to withdrawal management plus psychosocial treatment alone, the results are incredibly impressive. This was an early study published in The Lancet comparing individuals with heroin use disorder who are randomized to buprenorphine maintenance treatment versus randomized to withdrawal management and then a year of intensive psychosocial treatment, and found that the group that received buprenorphine, 75% of people had a negative toxicology for opioids and were still engaged in treatment, whereas the group that got randomized to withdrawal management and psychosocial treatment, no one was still engaged in treatment, and actually 20% of the population was dead within 1 year. So really dramatic differences when we look at the life-saving and effective potential of buprenorphine as a treatment for opioid use disorder. On the country level, this was an observational study done in France, looking at what happened when they expanded access to buprenorphine and methadone treatment. When France was in the midst of a heroin overdose crisis in the 1990s, they allowed any practitioner, any general practitioner, to prescribe buprenorphine. There were no limits or restrictions the way the United States has had historically, and they were able to get 90,000 patients treated in less than a decade. And they saw a 5-fold reduction in heroin overdose deaths, a 6-fold reduction in active injection drug use, and a decrease in HIV prevalence. The other good news is that most treated patients will achieve remission. Opioid use disorder is a good prognosis and very treatable health condition. This was a multi-site clinical trial called the POTE study, which looked at buprenorphine as a treatment for prescription opioid use disorder. And there was a second part of the study that followed part of the cohort out into 3.5 years after enrollment in the trial. And they found really remarkable long-term findings. Of course, 100% of individuals had opioid use disorder at the start of the trial. That was one of the criteria for entry into the study. But by month 42, fewer than 8% of people still met criteria for opioid use disorder. So 92% of people in this buprenorphine treatment study no longer met criteria for opioid use disorder. That is remarkable and a reminder of just how treatable this condition is. When we think about primary healthcare and other healthcare settings, these are really opportunities to engage with people and start treatment. And there have been a number of studies showing that initiating treatment in general healthcare settings is a really wonderful opportunity, and people are more likely to stay in care. One study found that when they looked at individuals getting hospitalized who had opioid use disorder, if they offered methadone treatment initiation while the person was in the hospital, 82% of people would present for follow-up addiction care. A group then did a randomized controlled trial where they took, again, all comers to an inpatient general medical hospital, and they randomly assigned them to either starting buprenorphine in the hospital and getting connected directly on to buprenorphine treatment in the community, or having withdrawal management in the hospital and then getting a referral of buprenorphine treatment. And they found that that seamless linkage of starting medication and continuing it had a huge impact. 72% of people entered into treatment after discharge if they were started on buprenorphine and continued, versus only 12% if they got withdrawal management and referral. A group at Yale here in the United States then took that a step further and looked at initiating treatment in the emergency department. They did a 3-arm randomized controlled trial where they randomized individuals in the emergency department to starting on buprenorphine in the emergency department and getting a prescription to connect them on to ongoing buprenorphine treatment, versus doing a motivational intervention or just referring people to treatment, and found that just that short 3-day prescription of buprenorphine started in the emergency room had a huge impact. 78% of people would continue on in care if they were started in the emergency department, versus only 37% of people if they were referred but without the medication. We also know that buprenorphine treatment is very effective in primary care. This is a randomized controlled trial looking at primary care management only of opioid use disorder, where the primary care doctor prescribed the buprenorphine and provide medical counseling, versus primary care management plus specialty addiction counseling with cognitive behavioral therapy. And they found no difference in outcomes. So there was no difference in opioid use, study completion, or cocaine use between the two groups. That's not to say that high quality voluntary psychosocial treatment isn't important, but it is to say we can do this effectively in primary care even without additional specialty resources. The National Academy of Science, Engineering, and Medicine summarized many decades of research around medication treatments in this report that came out in 2020 called Medications for Opioid Use Disorder Save Lives. And their 6 conclusions sort of said it all. They said medication-based treatment is effective across all settings it's been studied in. Withholding or failing to have available all types of medication for opioid use disorder is denying appropriate medical treatment. So that is a pretty strong statement that if we are not making medication available to people in all care settings, we are denying appropriate medical treatment. So how does a primary care doctor actually provide treatment for opioid use disorder? Well, much like any other health condition, you want to identify the patients who are affected, and that can be through screening or when someone presents with an acute presentation, like after an overdose or with an infection related to injecting drugs. You want to make a diagnosis and talk about that diagnosis with the person who is affected. You want to initiate treatment without delay, and then help retain patients in care over time. So how do we make a diagnosis of opioid use disorder? We base that on the DSM-5. So there are 11 criteria. And opioid use disorder is defined as really continuing to use opioids despite negative consequences in your life. So having a problematic pattern of opioid use, which leads to clinically significant impairment or distress, manifested by at least 2 of the following criteria occurring within a 12-month period. Depending on how many criteria someone meets, they either have a mild, moderate, or severe opioid use disorder. And the criteria really get at the hallmarks of addiction. We sometimes talk about the 4 C's of addiction, and those stand for compulsive use, loss of control of use, cravings, which is a strong psychological urge to want to use the substance, and then use despite consequences. And so these criteria ask about those factors. So are you using more than you intended to? Have you tried to or wanted to cut back and not been able to? Are you spending more and more time using or recovering? Do you have cravings to use opioids? Have you continued to use despite failure to fulfill role obligations or social problems? Or have you given up important activities because of your use? Have you continued to use in situations that are physically hazardous? And have you continued to use despite knowing that it's worsening a physical or mental health problem? There are 2 physical criteria, tolerance and withdrawal. Tolerance is needing to use more to get the same effect. Withdrawal is getting sick if you were to stop using. And it's important to note that those 2 criteria alone are not enough to make a diagnosis of opioid use disorder if someone is being prescribed a medication, because anyone prescribed opioids long-term will develop tolerance and withdrawal, but they don't necessarily have an opioid use disorder. So once you make a diagnosis, you talk about it with a person, you then want to start treatment without delay. And when we think about effective treatments, there's really 4 kind of things on the menu of options that I think about. First and foremost is medication, which again is the most effective treatment we have. Psychosocial intervention should be high quality and voluntary. No one should be required to go to those as a condition of medication. Recovery supports are not formal treatment, but can be incredibly powerful. Engaging with people who have the same shared lived experience of you, who themselves are in recovery, can be a wonderful way to build up a foundation of support. And then harm reduction is really an approach that aims to reduce the negative consequences of drug use, irrespective of whether someone is able to or wants to make changes to their drug use. And to me, it's not harm reduction on the one hand and treatment on the other, but rather those are all a part of the same approach and same continuum, much like with any other chronic health condition. As an internist who is also addiction medicine physician, I really think of this as very similar to managing diabetes or HIV, where our goal is to prevent acute and chronic complications from untreated disease. And we have tons of science to guide us in what are effective treatments and interventions and what targets are we aiming for. But we then have to tailor that to the individual person who's affected by the disease and really think about patient-centered and patient-driven care. Even the list of options of treatment looks very similar for diabetes or for opioid use disorder. Treatment includes medication, behavioral support, lifestyle changes, and ongoing regular monitoring. So medications, as you've heard, are the most effective treatment we have for opioid use disorder. Buprenorphine and methadone are the two most effective medications that exist. And their goal are really kind of four main reasons why they're so helpful. First, they relieve the pain and suffering of withdrawal. Withdrawal is agonizing, and fear of withdrawal is also incredibly stressful and will keep people from coming into healthcare spaces, from being able to engage around their goals or their needs. And so relieving the pain and suffering of withdrawal is the first immediate need. They also block the effects of other opioids so that if someone has taken their buprenorphine or is on a therapeutic dose of methadone, they don't get the same euphoric effect from other opioids, and that helps reinforce their recovery. Importantly, they reduce cravings, which is that strong urge to want to use opioids. And that's often what drives people back to using opioids even after withdrawal has been managed. And then, as you heard me say, they are life-saving. They reduce overdose and they reduce mortality. And that is hugely important, especially given the ongoing overdose crisis. Buprenorphine is, in the United States, the only office-based medication that we can prescribe. So we are not allowed to prescribe methadone. Methadone has to be dispensed out of opioid treatment programs. And so for primary care doctors, it's really important to understand how buprenorphine works. Buprenorphine is a partial opioid agonist at the mu opioid receptor, meaning that it activates the receptor, but only partially, and there's a ceiling effect for respiratory depression. That's very important because it means there are fewer side effects in terms of sedation. It's also really essentially impossible to overdose on buprenorphine for a person who has opioid tolerance. The next important thing to know is that with higher doses, we've seen that there are actually increases in retention and treatment and abstinence rates, and it's likely as effective as methadone. Early on, when buprenorphine was first being understood, the thought was that methadone was maybe more effective at retention and care, but many of those early studies were looking at too low of doses of buprenorphine, and therapeutic doses of buprenorphine are very effective and likely as good as methadone. It's effective and safe in pregnancy and in breastfeeding, and in fact, treatment with buprenorphine or methadone is recommended in pregnancy. The other pharmacokinetic piece of buprenorphine that's important to understand is it has a high affinity for the opioid receptor. So it has a partial agonist effect, but a very high affinity, meaning that it can displace other opioids from the mu opioid receptor. That means if someone has just used fentanyl or just taken oxycodone and they take a high dose of buprenorphine, it will displace all of the full opioid agonists from their receptors. And that drop from full effect to partial effect will be experienced as being precipitated into withdrawal. And so because of that, you have to wait until a person is in mild to moderate withdrawal to start buprenorphine. We use an instrument called the clinical opioid withdrawal scale that allows us to objectively measure opioid withdrawal. And once someone has a score of 8 or higher, it's safe to start buprenorphine. That's usually around 12 hours after their last use of a short-acting opioid, or 72 hours for methadone, which is a much longer-acting opioid. There are also newer models of starting buprenorphine that I'll touch on briefly, especially something called low-dose initiation. So in terms of starting buprenorphine for a primary care doctor, they need to confirm that the patient has a diagnosis of opioid use disorder. They want to explore what are the patient's goals? What's their treatment history been? Have they had periods of remission before? Have they tried medication? Do they want to start buprenorphine? Then want to utilize that encounter as an opportunity to engage around other health screening. And this is one of the reasons why it's so great to offer opioid use disorder treatment in primary care, because you can also do HIV screening, hepatitis screening. You can offer hepatitis C treatment, vaccinations, and really have that be an opportunity to engage around the holistic health needs of the individual. Want to incorporate harm reduction practices. For many people, the journey to recovery is not going to be a straight line. And so talking about naloxone to prevent overdose, drug checking if that's available, safer use practices, discussion of pre-exposure prophylaxis for HIV prevention if someone is sharing injection equipment. And then you want to start buprenorphine and arrange follow-up, much like for any other medication treatment for a health condition. In terms of starting buprenorphine, the traditional dosing would be to wait until someone has a COWS score of 8 or is in moderate withdrawal, give them 4 milligrams, have them wait 30 to 60 minutes, and if they're still experiencing symptoms, to take another 4 milligrams, and then they can take 4 to 8 milligrams every 6 hours until they get to a dose that they feel comfortable on. For most people, that daily dose is 16 to 24 milligrams a day, although in the era of high potency illicitly manufactured fentanyl, some people are requiring higher doses like 24 milligrams and above. Then on days 2 to 7, that person would just take that total daily dose either as a single dose or divided. So if they found they needed 24 milligrams to get comfortable, they could take all 24 milligrams in the morning, or they could take 8 milligrams 3 times a day. There are lots of new opportunities around different ways of dosing buprenorphine to start it, and the two most common are low dose or high dose initiation strategies. Once you start someone on buprenorphine, you want to check in and follow up and see how they're doing. That is frequently at first when someone is just stabilizing, but as they stabilize and are doing well on the medication, the frequency of those visits can space out, much like any other chronic condition. What happens in those visits for a primary care doctor? Well, they want to evaluate how the person's doing. Are they having symptoms, cravings, withdrawal? Have they had any episodes of use? What are the benefits or any challenges with the medication? Do they need additional support? Do they need more psychosocial treatment? Do they need other recovery supports? And then to really anchor all of that in the patient identified goals. So the reason that they think that their life will get better if they make changes to their opioid use. All of this is framed in an idea that people don't fail treatment, but treatment can fail a person. So if someone is not doing well and continuing to use opioids, it's not because they're bad or they've done something wrong. It's just that we haven't found the right treatment plan. And so we want to modify the treatment plan to find what's going to work best for this human being. And so that might be increasing the dose of buprenorphine. It could be increasing supports like psychosocial supports, working with a recovery coach, going to more support meetings. Or if the person's really having a lot of challenges, maybe methadone would be a better medication. And so we're thinking about trying a different treatment intervention. And then, of course, throughout incorporating harm reduction, making sure that person has naloxone, that they're not using alone, and that you're talking about universal overdose prevention strategies. The take-home points for primary care-based treatment of opioid use disorder is that increased access to opioid use disorder treatment is desperately needed in primary care to address the overdose crisis. Opioid use disorder is a treatable, good prognosis health condition, and treating it is not only feasible in primary care, it is incredibly fulfilling. And like other chronic conditions, it can be diagnosed, treated, and managed in general medical settings, ranging from the emergency department to the hospital to primary healthcare settings. Thank you so much for your attention, and thank you for having me.
Bueno, muchísimas gracias, doctora Sara. Dejamos como aprendizaje.
Thank you, Dr. Sarah. One of the learnings from your presentation is seeing the results of treatment with the available medicines and the effectiveness of treatments. Likewise, you also pointed out significantly that treatment should be overall. Treatment is for the whole patient with psychosocial components, support groups, strategies to reduce harm, as you mentioned, but it also needs to include medications so that we can truly decrease mortality due to opioid use disorder. Likewise, it's important to in order to manage the problem of OUD and other disorders related to OUD, we need to treat that as a chronic disease, and the use of medicines to decrease risk of overdose were mentioned by you. And uh, um, buprenorphine is being used here in North America. In other countries, in the rest of the Americas, methadone is used, but it has been very interesting to hear about the use of buprenorphine. And for the end of our event, now we would like to have discussion with two of our guest countries. They are invited to make a short presentation so that they share with us the situation in their countries and their challenges. And maybe they can be extrapolated to situations in other countries in our area, in our region. First, we invite Dr. Luis Eduardo Sandiez. He is a psychiatrist and he has a master's in public health, and he is a researcher and teacher also at the Institute for Alcoholism and Drug Dependency from Costa Rica. Over to you, Doctor. Good morning, and thank you for inviting me to share. In Costa Rica, we have the Institute, uh, which deals with OUD and alcoholism, and we have had for 15 years, we've already had an opioid clinic for OUD. Basically, the situation in our country, Costa Rica, is that the problem is related to legal opioids. We have no prevalence and we haven't found any evidence of illicit opioids. And there is no heroin consumption in our country. In the latest study in 2022, we uh, saw 3% use of legal opioids. And we didn't find evidence, I repeat, of the use of heroin or fentanyl. People who uh, use these drugs are foreigners usually. In the treatment centers for OUD, we had 1,800 patients hospitalized in 2023, and we found 0.38% of patients hospitalized for use of legal opioids. Uh, in the ambulatory emergency center from 2011 to 2019 to 2023, we had uh, uh, in 2019 10 patients coming in, and in 2023 there were 113. So there has been an increase, and it was a big increase, attending the emergency or urgent care. The population has been made aware that there is a clinic to treat OUD. But so far, we have had no use of fentanyl, no use of heroin, and no deaths due to fentanyl. Again, I repeat, they have come to the clinic for two different reasons. And we have to differentiate between uh, addiction to opioids and uh, overdose. People start using opioids because they have an underlying situation. They've had a complicated surgery, they have chronic pain, etc. So those conditions lead to the use of codeine and other similar medications. And over time, these drugs become cause dependence and tolerance. And so the patients maintain the same dose for 5 years. They take 3 or 4 vials a day, etc. And it is legal. And I would say that there are 20% of those patients who become addicted and they really binge on the opioids, and they are losing control, which is the behavior, the sine qua non behavior for someone who's addicted. So these different cases require different types of treatment. In our clinic, we have one psychiatrist, that's me, and then we have nurses, and we have a social worker, and we have a questionnaire for drug addiction. And we think it's important to obtain um, informed consent. The patient doesn't have clarity as to how much they are consuming and how often. So we need to obtain their informed consent and to determine and be able to assess and make an accurate diagnosis. Once we have made the assessment, we begin to use methadone, and then we also start them on psychosocial treatment. There is good acceptance for people to start working with us, and they have therapy, either group therapy and family interventions. And we connect these patients with Narcotics Anonymous groups. We give immediate treatment to the addiction, a 12-step program, follow up, uh, and when treatment with methadone is given, we give initial dose, and then 48 hours we see toleration or tolerance, sorry, and reaction to the medicine. And then we adjust and tweak the dose, and we keep them, and we taper the dose weekly until it is stopped. And then they are given alternative treatment with tranquilizers, in addition to the psychosocial support with groups and therapy, physical therapy, good nutrition, and many of these patients have physical, structural, medical conditions, and then they need to be assessed. Maybe they have a disc hernia or migraine, situations that they've had, these conditions that weren't really the initial problem. And the patients then were not really treated for their initial condition because they became addicted. Once we treat them for the OUD, we find out that these patients had difficult conditions. The patients requiring more intensive care are patients with a consumption history of other drugs, and people with associated conditions. Those who are just physically dependent on these drugs have no more complex history, then that's a different group. If people have addictive problems in the past, then they have a certain set of behaviors. And in this case, the treatment needs to be more intensive, and they need to be supported by 12-step programs. We work not only with the groups, but with the families. Uh, uh, Many times patients need to manipulate or minimize, and treatment is complicated, which is why we need to work with the families. If also, if patients have jobs, we need to also work with their job site. And we also have many healthcare workers, nurses, etc. So how can we make sure that nurses and doctors who work with opioids already, we need to treat the behavior and remove them from work even for a time to strengthen treatment and make sure that they are truly taking treatment seriously. And we do it with urine tests, follow up with patients, follow up with the family, follow up with groups. And these patients need to be relocated to a different line of work, maybe where they can go work where there is no opioid management. They and then make sure that if the patient has become sensitized, if they had accepted their disease and are on the road to um, success. I have to say that we have been quite successful, and we have 4 clinicians working weekly, monthly with these patients and very intensively, up to 2.5 years, until we are sure that we have succeeded in the treatment. This is our experience. And I think with methadone, with psychosocial treatment, with working with the families, with 12-step, with all of these different things, we have been able to succeed.
Thank you very much, Luis Eduardo. I have a question. It might be that Dr. Sara may help us answer this, because Costa Rica has a very specific situation that may be the situation of many countries in the America, whereby there is no heroin or fentanyl use, illicit use. But Dr. Sara may probably share with us the story of the 3 waves as to consumption and use of opioids in North America. And the concern could be, Dr. Sara, that Costa Rica and some countries are in the first wave. That is to say, they're not using heroin, they're not using fentanyl, but they are using opioids. In particular, they are misusing opioids as medicine. What is the recommendation you have for us, Dr. Sara, given the experience the US has, the Northern Hemisphere countries have had with this, so that we can share this with the rest of the Americas?
Doctora Sara, está silenciada.
Dr. Sara, you are muted. Are you still with us?
Yes, I'm so sorry. Can the question be translated?
Doctor, you need to choose the English channel.
La experiencia de Estados Unidos con las tres ondas.
We wanted you to share the experience of the US with the 3 waves, the 3 stages of evolution in the use of opioids. First, the improper use of medicine, then the use of heroin, and then the use of fentanyl rather, because Costa Rica told us that they do not have a serious problem, or that they do not have a problem with the use of illicit drugs. But what is your recommendation given the specific situation, what happened in the US that may happen in countries in the rest of the Americas?
I think I understood mostly. I'm going to try to answer. The United States is very unique in our current overdose crisis, and I think there are some reasons for that. The start of our current crisis was because of differences in prescription opioids in the United States, where starting in the late 1990s, there was a massive increase in how opioids were prescribed for pain, for particularly non-cancer chronic pain. And that led to increased amounts of prescription opioids in the community and people using prescription opioids non-medically. That was really from 1990 to around 2010. And there's been a shift in the crisis since of heroin and fentanyl use overtaking that. I think the reason the US has such a high death rate that's disproportionate to other parts of the world started with the story of prescription opioids, but also more recently has really been because of how poisoned our drug supply has become and how unpredictable the opioid supply in the US is, with fentanyl coming into the market. So that a person who's using opioids, it's very hard to keep yourself safe. They have no idea what the potency is of what they're using. I think there are also some philosophical questions of what is it about the United States and our culture that drives such problems around chaotic drug use in the first place? And I think that's a very long question that doesn't have a specific answer, but there are specific things I think that could reduce our current crisis in terms of the overrepresentation of fatal overdose and mortality rates in the US compared to other countries.
Muchas gracias, doctora Sara, por su respuesta. Le damos ahora la palabra
I thank you, Dr. Sara, for your response. And now we give the floor to Dr. Esteban Pizarro, who is an economist who has a master's degree in public health with the University of Chile. He leads the Chilean Drug Observatory and also the Early Alert System for Prevention and Rehabilitation after Drug Consumption and Alcohol from Chile, the organization SENDA from Chile. Thank you very much, Dr. Zapata. First of all, I would like to thank you and Pajo for the invitation to talk to you regarding the use situation of opioid without the opioid use in Chile, and also the point of view of an agency that is working on drug reduction in Chile. Now, as to the use in general in Chile, leaving aside tobacco, marijuana, alcohol, and vaping, we have a prevalence rate of 2%. I'm talking about cocaine, base paste, and others. And now, regarding these opioids, over the last 15 years, we have seen in population studies an important increase in the presence of these drugs in our country, and they represent about 1.5% based on the last national drug study. And also, as to the access pathways, we should say that a great deal of access is accounted by the immediate access, by unregulated sale, relatives, friends, and also the obtaining these drugs from pharmacies with third-party prescriptions. We have also seen that starting in 2020 and to date, these pathways that were mainly related to the immediate circle of individuals, now we see a trend to have access by means of small informal markets. Within that context, I also take up this opportunity to refer to the phenomenon of synthetic drugs and the emerging drug phenomenon that is also part of this broad analysis of the situation, and also mention that we see with concern that this is an upward trend and that this group of synthetic drugs that include ketamine, ecstasies, methamphetamines, etc., are also representative 1.2, 1.5% of the population. And in that regard, when we look at this phenomenon from the agency, we see with concern that there is also ecstasies and other drugs that are coming in through the border and other sectors such as the veterinary sector, and also some hospital needles that do have the product. So, and in connection with our colleague, with what our colleague said from Costa Rica, we said we do not have the illicit fentanyl problem in Chile. We issued an alert in early 2023 about illicit fentanyl and also the seizure in our country, but this was part of a substance that had other 6 drugs. So at the end of the day, it is a mixture, and we cannot say that we have an actual problem. Now, as to the trend, we see a threat for the diversification of the use of drugs and also the presence of mixtures that are unknown to the individual. The user does not know the content, what the content is, and also the use of other drugs that were more related to the vet section, such as ketamine, and also the imminent threat that we have with fentanyl. As to opioids, we need to look at the situation again and look at control, distribution, and access by the general population to the drugs. And we have already had politicians that since early this year have implemented the 2024-2030 drug action plan within the framework of the national drug strategy that is part of a plan developed with institutional cooperation and also the participation of the citizens, and beyond having the main focus on prevention, treatment, and social participation. We have specific guidelines as to how to address the emerging drugs, and that includes the strengthening of the early warning system, improving also the registration and also consumption registration system. And this is something that is related to actually control any marketing of pharmaceutical products. And also in parallel, the drug observatory, and also within the strengthening of the early alert system, we are also creating an intersectorial system with the public institutions that goes from the police forces to the labs, customs, and also health-related agencies under 4 principles. The first one is related to strengthening monitoring and follow-up. That is, how can we better trace the seizure as well as the epidemiological surveillance by means of designing wastewater studies, and also how we can develop and look at the surveillance of health instances that have to do, for example, with the poisoning with these substances. And the second one is related to what Dr. Cano said in her presentation. We need to determine how we are ready and to prepare the first responders, and this has to do also with identifying the actors at all levels, from the level of health practitioners to customs officials, and also providing the right antidote. And in that case, the country is already working on having naloxone available in the spray presentation. And also this includes health individuals having this available to provide treatment. The third one has to do with strengthening control mechanisms in a broad sense. And we need to see how we can update our regulations, our rules on active substances. And fentanyl was added in 2021, and there was no presence in the national territory as to the illicit fentanyl. And we need to see how to strengthen the medicine, the drugs that are used for human beings and animals. And also the final axis has to do with the management and risk communication. How is it that we can identify the specific populations that use substances, and also what would be the paths to provide information from the state to the population to reduce risks and damages or harm. And finally, data that has to do with unregulated use of opioids and synthetic drugs show us that this is becoming a public health problem in our country, in particular because of very specific situations. And in these areas, we need to strengthen and also foster better knowledge about the use of these substances, and also diminish the access to drugs or pharmaceutical products. And we also understand that from this action plan and also the strengthening of the alert system, we can protect our population from the opioids and these new drugs. And I am willing to answer any question or comment that you may have. And once again, let me thank you for the invitation to participate. Thank you very much, Dr. Esteban. And to conclude the event today, we can mention that the increase in drug use in America, and also the increase in the use of opioid also increases the burden of disease in countries of the Americas, and this should also create a warning and an alert for all of the countries in the region. There are also effective treatments for the poisonous effects of these drugs with methadone and buprenorphine, and these should also be available at the level of primary health care to prevent the worsening of disease and also the death due to this problem. And public health plans and care in the countries should include as part of their priorities care for psychoactive substance use and also the development of specific actions to reduce the non-medical use of opioid. We thank the presenters today, their time, and also we thank our countries that have attended the meeting today. Costa Rica, Chile, also thank you for your generous offer to stay here with us, and clearly we thank all of the attendees to the webinar. We invited to be on the lookout for more information, more webinars on our webpage with PAHO, and also we will continue to share information on the psychoactive substances from PAHO. Thank you very much and have a good afternoon. Thank you. Good afternoon. Thank you, and I wish you all a very nice afternoon. Goodbye.